Thanks very much, Jerry. It's lovely to be here. And I'm going to try to translate all the elegant generics that you've heard in a more clinical sense to you. What to do when your patient comes to you asking you to help with their child. This is a child who came to us rubbing her eyes because the mother was quite sad that the child was not looking at her face. It's a sort of situation where when on rubbing the eye, the patient is able to feel happy and it generates phosphines. When I asked an adult patient why she did this, she just said it felt good. It felt like sort of rubbing an itch. These patients have very difficult situations when they are born because some of them present with wandering and roving eyes. They're quite photophobic. On the other hand, there are those who just stare at the light. Every time the light is turned on in the room, a child who's not interested in anything else stares at the light. An older child often presents with night blindness. When we were in medical school, we were always taught that if you looked into an eye and saw a normal eye, fundus, with just decreased pupillary responses, and the child didn't see, it was a rather grave situation. We sort of cemented the diagnosis by doing an electroretinogram which was fairly flat or had very little response because their photoreceptors were not functioning very well. So this is a rather grave situation, and it's like a terminal form of RP and a very disturbing diagnosis to give to any family who's going to face looking after a child who's not going to see very well in any country and in any place. So these patients who present with this disease mostly belong to an autosomal recessive subgroup, very common in the south of India where we marry our relatives. Sometimes we even marry our uncles. And in the Middle East, they marry their cousins too. So it's fairly common, and the gene frequency is more common in these patients. It also presents quite early in infancy with nystagmus. Labour described this condition a long time ago, along with other conditions which we are familiar with. He's quite a hot favorite in ophthalmology and in ophthalmology quizzes, so he's done a lot for us. But what he designed early was the heterogeneity, which he was keenly pointed out quite early in the disease, because we have different forms of this disease, which affects about 1 in 3 in 100,000. And it accounts for 5% of all inherited retinal dystrophies, which is quite a large number. Now currently, we identify about 65 to 70% of the genotype in these patients, which is quite phenomenal because in the last decade, we've been able to achieve a lot where this disease is concerned. What really is autosomal recessive disease? It's where both parents have the blue spot of the side, which is the affected gene that's not functioning very well. And when they both come together in the last daughter, as you see on that side, she gets the disease. Whereas the other two who have little blue bits are just carriers. And if they go on to marry relatives who are carriers, then the disease gets manifest. And there's a 25% chance of an infection if both parents are affected. So heterogeneous disease, as I talked to you earlier, but also remember our patient who comes and sits in front of us has a full body. Don't forget that they're connected to other organs, the eye. So it's important to ask about milestones and to pick out if these patients have other diseases with them. There's no point in saving a child and losing the child to a nephropathy, which is what happens in senior Loken syndrome. So be sure to ask your patients and have them screened for other conditions like neurodevelopmental delay or even nephrotic problems. Why is it important to make a diagnosis genetically? Because we as ophthalmologists fail if we don't treat the patient as a whole. And this patient who came to me was a boy, and he was the third child of a family. The parents were told that the children that they had earlier had toxoplasmosis because they had a colobomatous-looking macula. So the mother went on to have more children each time because there's no family history of blindness, and all 3 children had labors. So it's quite disturbing that in this day and age we are not making the right diagnosis. The father was a policeman and they lived in the south of India. So he was very disappointed that none of his children could follow what he did. Nevertheless, the girls went on to become lawyers and the child is still in school. They also have other findings associated with Leber's congenital amaurosis. Patients sometimes have keratoconus. If you, for example, examine children in a blind school, they have keratoconus and high drops and a completely opaque cornea, and you really don't know what disease they had. So, and these children just stay in the blind school because they don't know what affected them. So it's quite important, even if you stay in places where children haven't been screened, it's important to screen them because we can treat the keratoconus and give them some form of rehabilitation, and at least we know the diagnosis if they have LCA. And Saldino, which is the second disease, is associated with epiphyses which are quite distal and large, senior locum with nephropathy, and you also have hepatic ducts which are deformed in the DeBacon syndrome. So watch out for these, and in Joubert they have cerebellar aplasia, and these children are a bit unsteady. So don't just classify kids as not doing well, disturbed, learning difficulties, spastic, CPs. They all have a diagnosis and we can all help them. But arriving at that diagnosis sometimes is a bit of a journey. There are mutations in this gene that are quite extensive. And I think that this disease has been studied so phenomenally because it's such a terrible diagnosis to have. It also helps us to understand RP, which is more common. 1 in 3,000 of us get RP. And this paved the way of trying to understand what happens in lesser involved fundus diseases. And we understand that, genetic blindness because of LCA can also have other genes that are affected with it. So this is a little diagram which shows you things that are happening when you see patients with congenital blindness related to LCA. And all the genes involved in this disease are affected because of different functions not working well. And every little thing counts, as you might have all realized in ophthalmology. Our cells just losing one cilia and a few cilia can give us blindness. And that, I think, is quite horrid. So I think we better get our skates on and find some cures for diseases of the retina instead of racing after one more way of taking out a cataract. So I think that OMIM, which is the genetic page, if you've not been introduced to, tells you a little bit about genes, diagnosis, phenotypes, and genotypes. It's an excellent facility for you to look at on the net. It comes up in the downstream of the PubMed menu if you're not familiar with it. Illustrating genes, mutation hotspots, and what they do in different genes. Because it all gets us closer to trying to understand gene function, and with gene function comes therapy, because the genotype is going to describe how we are going to make therapeutic options for our patients. So looking at a beam of light becomes very important. The first gene for LCA was GUCY2D, which we see here, which was a phototransduction cascade gene. And after that, the RPE65 gene, which we talked about earlier, for which we have some form of gene therapy, which is working reasonably well, is now in the 4. So I think that when you look at rods and cones and all the mutations of LCA, this is a rough division. It differs in different populations, and some genes are more common in terms of their mutation than others. So the frequency varies dependent on where you practice and who your patient pool is really. And remember that some of the patients might have LCA, their relatives might have cone rod dystrophy, or they might even have ARMD sometimes. So it's a very complex situation. And some of these genes cause milder forms, just like cone rod dystrophy in patients, where patients can see but they are not seeing that clearly in certain kinds of light. So it's a whole spectrum, so you don't know what to call the animal that, walks below. Here's a patient with CRB1 mutations, whom we described in Palestinian families quite early on, but you also have a large number of Indian families with this mutation. CRX, along with another gene called the IMPD1, it also causes LCA in the dominant variety, where the mother and the daughter can have the situation of having LCA. Pictures showing you different phenotypes. So don't be disturbed when you look into the fundus and see all this. It's still worth screening them for the disease and for the genes written below, because there could be any kind of phenotype in the current studies that we have tried to focus on. Here's the patient on the top there with the AIPL1 mutation, quite similar to the child I described to you earlier, whose father was a policeman. So the retina looks disturbingly atrophic in some of the patients, and in other patients it looks marvelously normal. How do you study patients who present to you with a disease? This is one of the first families I had the opportunities to study. They live in Pennsylvania. They migrated from Switzerland in the 17th century, and we went to their little village to study them, and they were very cooperative. The most amazing thing about them is that they had written down their genealogies very well. The rest of us who pass on heirlooms to families, this family passes on the book, who tells them who their grandfathers were and what diseases they have. And I think we should all take to doing that, because that's far more important than passing on a piece of gold to which we are sentimentally attached to sometimes. So this patient family had an LCA5 phenotype, and there were two children. The girl was more affected than the boy. And the girl was more affected because she also had a mutation in the GUCY2D gene, which is a phototransduction gene, in addition to having ciliary dysfunction on the labercillin gene, whereas the boy had a mutation only in one. So he was not as affected. Now, it took a little girl to come along for us to identify the mutation in this family, because, or rather to identify the locus in this family, because it helped us narrow down the region. So having large families in genetics helps us a lot, because we are looking for that one little situation where things aren't perfect. Chromosome 6, that we got quite attached to when we were studying this disease. It also has other retinal genes that live there. And that's a picture showing you the little area of the cilia, which is what is not functioning very well in this family, right? And the immunofluorescence that looks beautiful. So cilia became quite important not only for ophthalmology, but in so many other diseases. Carcinogenous syndrome, where you have lung problems associated with problems conceiving, because the male sometimes is not functioning, the sperms are not functioning very well because the cilia isn't working very well, is one of the diseases you might be familiar with from medical school times. And ciliogenesis has become very important in ophthalmology now, even for Bardet-Biedl syndrome or Usher syndrome, where we worry about our cilia. In LCA, these are the three genes we are currently studying, although there are others down the pipeline. Jobert's, don't forget to have a scan on your patients, because you can make the diagnosis very easily, because they have a molar tooth sign on the MRI because of cerebellar, agenesis, which you can see quite clearly over there, right? And you need to pick out these patients. So genetics becomes very important because of its modifiers, interactions, and heterogeneity. And we need to screen not only the exonic region sometimes, because introns and promoters also change the way genes interact. I think my colleagues pointed out to you all about microarrays and how they're good for helping us with diagnosis. So as you have a child come into your clinic and the parents want to know, what shall I do? What shall I do? We're living in a new century, and here's all this info from the net. The first thing you want to do is, at least after offering them the correct diagnosis, is to subject them to a microarray chip analysis, because it's a first pass analysis for screening, and it tells you whether the child has a known mutation. But you see, LCA now has so many genes, and all mutations may be private. Some mutations have hotspots. So it's still important, if you don't find a result on this, to go ahead and do more sequencing. Next generation sequencing is on here. Pictures just showing you how the apex chip works in patients, where we look at the colored dots. And I think that, as I explained earlier, the genotype is going to mandate how we treat patients. We've now treated mice, chickens, and dogs. So we've also treated humans. So I think that's quite promising for LCA. It's the way to go when we would think when there's proof of theory being tested, and several studies now having been done, and several patients who have the opportunity to see more than they had seen before this therapy. This therapy, as was explained earlier, needs putting the gene that's not functioning very well into an adenoviral vector and putting it subretinally, sometimes requiring a couple of injections. And their ERG improves sometimes. Their pupillary responses improve. And the child is able to see. It was a particularly lovely moment to see this patient commute this maze, which he couldn't do previously. And you can see a picture on the net. It was broadcast on all the TV channels. So this is when we thought, at last, the child can see, which I think is good, because even if a child has navigational vision, he's going to be independent. So we want to aim for that as the first step. And these are some of the patients who are happy after having their subretinal gene therapy. So it's hoped that we'll be able to treat more forms of LCA. AIP-L1, which is another gene, is being studied in the same kind of way. And we also have some other tests. So finally, there is light at the end of the tunnel. So I hope that brings some hope to us instead of not making the diagnosis in these patients. So when you're sitting in your room and you get this call to go and see a child who's not doing very well, and you head off to see this child, and this is what you see in the fundus. Again, not a very happy situation. A cherry red spot is quite devastating in ophthalmology because the rest of the fundus is gathering ganglioside, whereas that area is the only functional bit. It's particularly devastating because the child is very normal to start with, and they have psychomotor regression. So a child who's walking normally suddenly fails to walk and starts crawling. A child who's been looking at mom's face stops looking at mom's face. So it's quite disturbing for the family, and they run around to many places before they come to the ophthalmologist for the diagnosis, because they often get hypotonic and get disinterested. We in ophthalmology don't deal very often with death, but this is one of those moments which, if not, you don't understand the disease, you're going to have something else staring at you because you didn't make the diagnosis. So it's important to work very closely with your pediatric neurology teams. So this disease is Tay-Sachs disease. It affects 1 in 2,500 people in the Jewish Ashkenazi group of people. But nowadays they're all screened. All these people know who carriers are. And they try not to mate with other carriers because then the incidence of having this disease is quite high. And if they do, they indulge in what's called pre-implantation diagnosis, which is available in some parts of the country. So these patients too present very much like the patients with LCA. They have decreased central fixation, nystagmus, and decreased acuity, which is progressive. Thanks to these two chaps, Tay and Sach, the neurologist and the ophthalmologist, who made it possible to understand this disease. It's because a certain enzyme is not functioning very well. The lysosomes swell up, and you have deposition of gangliosides in the brain and the eyes. So you can actually test for this enzyme quite easily. It follows a recessive pattern. And it was actually the first mass screening tools in medical genetics. And I think that it's also a situation where people have tried to make life better for these patients. Here are pictures showing the bulging lysosomes, and you have very good EM pictures showing that there has incorrect folding of the cellular complex. This also presents as a juvenile form and as an adult form, which is not very easily recognized. So make sure to get your colleagues involved when you come up with this diagnosis. It's quite easy with a conjunctival biopsy. So enzyme replacement is currently an option for these patients. Gene therapy is being tried, and you can also decrease the substrate available. So you manipulate a little bit to make the situation easier so that the deposition is not so gross and there's a slow progress of the disease other than a rapid one. And it is possible to have prenatal diagnosis in these patients. So careful planning brings success. The common thing that you might come up with is refractive errors. Just be careful how we refract our patients, because when we see small eyes, we sometimes don't pay as much attention as when we see large eyes. I think we tend to treat more myopes. But remember, myopes don't become very amblyopic unless their myopia is very high. But you can easily have a child who's an amblyope if you don't treat them. So if you have even like +8 or +6 and you haven't picked it out, the child's going to have amblyopia. So nanophthalmos is the condition I'm talking about, small eyes. It can be isolated, or you can have a syndromic form. Just take care to look at the rest of the family when they come in, because our patients sometimes look a certain way, and we make the diagnosis based on how they look. So sometimes patients come in with extended families and you think, can I please look at your cousin? And you might make the diagnosis in this condition, as I will show you pictures of syndromic nanophthalmos. So because you have now dominant and recessive varieties where the eye is small and a big lens is scrunched up inside a small eye, and that's what gives them a lot of grief. These are syndromic forms, the oculodental digital type. So look at your patient's hands, it's important. And also check their retinas, which is very important in ophthalmology, because sometimes you think you've got an anterior segment problem and don't look at the posterior segment, and that will make you have the right diagnosis, because when this patient needs surgery, don't be offended if surgery is complex. It's because you didn't make the right diagnosis. Things are effusing as you cut into their eyes and you make a small opening for your phaco. And also when they go away, you find that they're not doing very well because their retinas have problems and you didn't diagnose it. And all of us feel rather sheepish when this happens. So I think that it's important to look at other things besides the retina. You see, you had to look at the periphery in this patient to make out that they had problems in the periphery of their retina. That's a very classic looking face, right? And syndactyly, as you see in this patient with this syndrome. So these patients draw their pedigrees. It helps with making out what kind of pattern of genetics they have, because it helps you make the diagnosis. OCT is freely available for your nanophthalmic patients. Plus, so look at their gonio, use your gonio lenses and look at their angles. Be careful if you dilate them. And also you see how their schisis looks. So this is a frizzled protein which we studied in the same group of people that I showed you earlier. They're also from a Swiss immigrant family of the Old Order Brethren who came from Pennsylvania. Fewer members affected, and when we needed DNA on one of the people who were deceased just to check if he carried the gene, it was marvelous. Somebody found his comb. So we were able to extract DNA from this gentleman's comb, and we noted that he carried this recessive gene. So it was important to understand this disease, and it's important to make the early diagnosis. There are several of these genes which are dominant, and the one that I studied was recessive. So pictures showing you how small eyes go with strange fundi and difficult surgery. So making the right diagnosis becomes important, and they also have decreased ERGs. Truly, we can manage the situation much better. We have good instruments now. We have lensectomies, we have phaco, we have IOL PARs that you can decipher more easily. So these patients lead a fairly successful life if the right story has been spotted. So I'd like to thank all my co-authors who helped me on this genetic road and the excitement of studying genetics. All our patients want is to see a little bit better and for us to hold their hand along their long journey, and I think we can do that. Thank you.